So I'm going to talk about some trickier fractures that required percutaneous fixation that I think the CurvaFix implant really was a benefit and can highlight in this particular um, type of patterns. Since I'm using the CurvaFix, I've really noticed some ease in terms of switching over to CurvaFix from traditional intramedullary fixation for the pelvis. And I think this highlights some of that in some definitely curved interosseous pathways. And I think there are multiple benefits to the way CurvaFix works, one of which I think is simply just ease of insertion when it comes to a curved intraosseous pelvic pathway. And the other we'll talk about throughout all of our presentations is the advantage of the increased stability that you get with a bent axle type construct. So I'll present two cases. This is the first case, and we'll talk about multiple different pathways. And at the end, please keep some questions in mind if you have any concerns about overlapping pathways or how to navigate that or how to think of maybe even a new pathway we haven't tried, but I'll show you some interesting ones. This is a 76-year-old male newly diagnosed with prostate cancer, had a very low speed MVA, like grocery store parking lot type MVC, and presented in pretty bad shape. He was banged up pretty bad. The airbag deployed. He was having a lot of internal bleeding and had some hollow viscous injuries. And he ended up with me after this initial scout image like this. So he got taken for an X-lap. And at our place, trauma X-laps never really get closed. So this patient came out of the OR packed with an Abathera wound vac on his open abdomen. And then he became more stable, but he wasn't really ready to be closed yet from an abdominal standpoint. After he came out of the OR with general surgery, we were able to finally get some good advanced images, and it shows that he has this LC2 variant where he's got a typical crescent fracture of his posterior right-sided iliac crest, and he has essentially bilateral anterior columns, a very essentially proximal floating symphysis type injury, where rather than we have really rami fractures, you have pretty high root of the rami type fractures with associated inferior ramus. And you have this obviously iliac crest with a little comminuted segment. So tackling this is a little challenging. And it also, you can see through on his upper right image there on the 3D that he has this sort of really complete anterior column component that comes down through the joint. So tackling this for me in the past was I need to work through an open abdomen. Maybe I'd like to smiley face plate this and make it fully stable from supraacetabular corridor all the way around to the contralateral supraacetabular corridor. And then also taking care of that iliac crest can be quite challenging getting that posterior for plating. And if you look at his two-dimensional cross-sectional imaging, I wasn't really wonderfully happy with his right-sided SI joint. I mean, if you look side to side, I think if I were to look at his right side in and of itself, I would have said, yeah, it's probably pretty normal. But if you look at it compared to his left side, it's definitely gapped. So I was a little worried about a subtle SI joint injury too, or at least an impaction type injury to the right-sided sacral ala, giving the actual joint some instability. So in this particular case, I just wanted to highlight some of the uses for CurvaFix and also that every corridor doesn't necessarily need to have curve fixation. In this particular case, I was able to stabilize first that SI joint with just a partially threaded compression screw in the S1 segment. And then just to stabilize, and if I thought I could catch a piece with this particular pattern of the fractured segment at the S2, it was a very close injury. I think I just got maybe a piece of it, but just to stabilize the joint a little bit even further. And then he clearly had the crescent injury, so he had standard LC2 type fixation. Now, in the case, and you can look at the guide wire image on the left, he did not have a straight shot corridor for an intramedullary screw. And anterior column fixation percutaneous, at least for me, has always been a bit of a challenge because the corridor to me is really very worried, obviously, superior penetration of the pubic ramus once you get past the joint and running into iliac vasculature, especially if you don't get a good obturator outlet view and see that true dip in the ramus. You can be out of the bone and having screw threads right up against the iliac vasculature and not even really know it unless you get the right view. So for me, a curved implant, or at least the ability of the implant to take a curved interosseous corridor, is really beneficial in that you can ride within the bone and not have to worry about things I used to do in the past, like bending guide wires to put screws through curved corridors, but still the implant being straight, and having to work that bent guide wire out of a straight screw. And even in some really osteoporotic bone in particular, I've had bent guide wires pull the entire screw out of the bone. So this is really where it's been advantageous for me, at least early on in my practice, or early on in my usage of this in my practice. And if you look, this is the starting point for a retrograde CurvaFix, retrograde Ramus screw, which I don't do often. Typically, I think this implant does really well for antegrade fixation, and I think it can be a little bulky if not deployed correctly right around the symphysis. But the way this lined up for this particular patient, I think it was best for fixation, the way his incisions worked out, and really navigating around that LC2 screw. I think I was able to get the implant, at least my plan was to get the implant past the fracture and to and maybe around the LC2 screw, or maybe stop short. But to come out at antegrade, I think that would have been a little bit of a tricky angle. So you can see that the start point for a retrograde CurvaFix, I try to keep as posterior or internal or medial into the pelvis as possible so it doesn't cut out the front. And these are some of the pictures of what it looks like driving the wire across this corridor. And I think this really shows, especially in the central and the right image, how not straight that corridor is, and how a curved implant can be beneficial in the sense that using that ball-tipped, curved, paddle-tipped wire, you can really use that ball, especially around subchondral bone and cortical bone, to deflect away from structures at risk and stay interosseous within the cancellous bone. It's actually really easy to do when you have really healthy, strong bone. This person wasn't that old, 76. I think the blastic metastasis of his prostate cancer probably helped bulk this up in terms of its density a little bit. But this stays in bone very nicely. And I think one of the early tips and tricks of getting this implant to work well for you is that as you're changing your trajectory and spinning the wire to change the angle, you're tapping along as you're doing that so that the vibrations of the wire help spin and rotate within the bone. And you don't just get this coiling effect where the tip is fixed and you're trying to spin and turn and you get a twist and coil on the wire, which can, if you keep coiling and coiling, of course, it will end up breaking. So just a gentle tap as you're spinning, and you can see going from the far left image to the central image where you have essentially a 180-degree turn in that wire, you're able to navigate that corridor. And looking at the far right image on the inlet, you can see that the corridor is also not straight in multiple planes. So this is what it looks like as the retrograde CurvaFix goes in. And you remember he also had a contralateral injury. And because of the way the CurvaFix sits, I was not able to start a retrograde contralateral implant, but rather an antegrade implant as well for the left side. So being able to utilize both retrograde and antegrade corridors in the anterior column is really advantageous, and it flows really nicely in terms of how it fills the column. And what I mean by that is if you think about a 7.3 millimeter screw or a 6.5 millimeter screw or a smaller than 3.5 screw, you can cannulate the corridor, but are you filling it up and getting that intrinsic internal fixation that you would also get, for instance, with an intramedullary nail when you get isthmic fixation? And I think with this implant, you definitely can add that to the fixation repertoire of this implant when you can fill the corridor up. It also helps with reduction and it makes it quite stable. You'll also see that with that anterior column screw for the left side of the pelvis that's going antegrade, you can get quite distal and medial into the pubic body. And ideally, you can actually curve and come down and come a little inferior down the pubic body to really make a bend in the implant and gain additional stability. So this is what some other views look like. Now, the previous pictures for this case were while the patient's abdomen was still open. So I didn't want to do any open fixation while his abdomen was open. So knowing that I can get these tough corridors as well with a curved implant was very nice. And in this particular case, I think you can see how the retrograde implant overlaps with that antegrade LC2 screw. Or rather retrograde LC2 screw. And then also once his belly was closed and he was stable, this was on a second day back to the OR, I was able to plate his iliac crest just to augment fixation. So these are his images at 6 months. He's a little further out at this point, but you can see the ability to really capture a very curved corridor. Both of those implants are not straight, and you can imagine potentially having a significant issue getting a straight screw through those corridors. The other thing that this really benefits from is the stability that's intrinsic to what I've previously stated, and I've talked to some other people from CurvaFix about, is the bent axle phenomenon, where you have a bent, rigid rod within a bone. And if anyone has ever treated a femoral nail that's been placed in the past that didn't break from a subsequent trauma but bent, you can understand how painful that is to remove that nail. And I've done that a few times, and it is a long day at the office when you cannot get that nail out because of its bent, rigid structure. That's essentially what you're intending to impart in terms of the bone and stability with this implant. So that additional stability lends me to be a little more aggressive with weight bearing as well. Now, for this particular person with a right-sided SI joint and pretty comminuted crescent type injury, I protected him on the right, but I was able to let him go full weight bearing on the left. And even by the protection, I was letting him do stand pivot transfers for the first 6 weeks and then letting him weight bear after that. So just some examples of antegrade and retrograde anterior column fixation.
So we're going to talk about parasymphyseal fragility fractures. So the objectives of this talk is pretty simple, pretty cut and dry. Just want to really give one clear message. The problem with parasymphyseal bone and fragility fractures of the pelvis, what will be abbreviated FFP henceforth, is to understand why that parasymphyseal bone is a problem. It's tough to fix. It's tough to manage, especially in these older patients with low energy pelvic fractures. We're going to talk about some potential solutions. The biggest thing is you really have to provide a strut against the internal rotation mechanism for the hemipelvis. And then we'll talk about just future progression at the end real quick. So let's start off with, this is an image that you don't want to have in your 2-week post-op follow-up visit. As you can see, this is an older patient that sustained a ground level fall. She had an internal rotation type injury to her right hemipelvis, where she had parasymphyseal fracture on that right side. And then she had right-sided sacral ala fracture as well. But this is the image that we want to avoid, where the entire anterior fixation with your standard retrograde screw has completely pulled out, and that whole right hemipelvis, despite the fixation in the back, has internally rotated, and it ended up healing in this way. But this is the 2-week post-op x-ray. So this is that same patient. These are the intra-op shots demonstrating appropriate starting point and trajectory for the retrograde superior pubic ramus fixation. That's a 6.5 millimeter cannulated screw, and good starting point. Inlet and obturator outlet demonstrate good placement. Here's the CT scan. I get a post-op CT on all my pelvises and acetabulums. And you can clearly see here, as we go from top left all the way to bottom right, that screw is in the parasymphyseal bone. Yet it's still pulled out. And this is what we end up with. So when you think about the anterior pelvis, I always think about it in the zones as described by Starr and Nakatani in their paper from 2008. You have zones 1, 2, and 3 of that anterior pelvic ring. Zone 1 is that parasymphyseal bone. This is everything medial to the obturator foramen. Then you have zone 2, which is the ramus that overlies the obturator foramen. And zone 3 is everything lateral to that obturator foramen. So the biggest issue is when you have fractures in zone 1 and zone 2. Zone 1, because the fracture occurs in the zone of really poor bone and narrow corridor. Zone 2 is a problem because you have to anchor or end your fixation in zone 1. Whereas the zone 3 fracture, you can have your fixation, whether you go retrograde or antegrade, you will get stable purchase in zone 2. And that's what we're talking about here. Zone 1 and zone 2 are the problem. So whether you go retrograde or antegrade with your fixation, if the fracture is in zone 1, you're starting or ending in poor bone. It's poor bone because the patient's elderly. It's poor bone because it's mostly all cancellous bone. You have a very thin cortex, and it's a narrow corridor to start or end your fixation in. And like I said earlier, even if you have that fracture in zone 2 and you have completely intact zone 1 bone, it's still poor bone to end or start your fixation in when you don't have a stable corridor next to the fracture. And again, this is all assuming you have appropriate posterior fixation, because if you don't, you're making your anterior fixation, you're really putting it at a disadvantage. So solutions. Like I said, zone 3 fractures, you're going to have good bone in zone 2 for your retrograde or antegrade fixation. So even if you start or end in zone 1, you're getting stable bone in zone 2 for a zone 3 fracture, if that makes sense. But the zone 1 and zone 2 fractures, those are the trouble. Those are the problem child, because you have to bypass zone 1, that parasymphyseal bone. You really need to bypass it because you need to get stable fixation on both sides of that fracture, medial and lateral. So how do you do this? If you go with a retrograde screw, your only fixation medial to that fracture is in zone 1. Poor, narrow bone. There's even likely some comminution there. That's the bone we're talking about. You can even try to cross the symphysis with the screw, but still you're in zone 1 symphysis and then zone 1 again. So you're still in poor bone, starting your fixation in poor bone. If you go antegrade, you're ending in poor bone. So there's no good stable fixation medial to that fracture, whether you go antegrade or retrograde. And this is kind of how we've done this for many years now. What you really need to avoid ending or starting in that poor parasymphyseal bone is you need to anchor your fixation in the contralateral zone 2 or even zone 3. You need a strut against internal rotation. So CurvaFix allows us to achieve that. So here's another patient, a fragility fracture of the pelvis. You have internal rotation injury on the right side, and you even have contralateral parasymphyseal fracture. So you have comminuted bone through zones 2 and 1 on the ipsilateral side. And then you have fracture through zone 1 of the contralateral side. So you really can't end or start your fixation in that parasymphyseal bone. So the only stable bone you have here is the supraacetabular bone on the ipsilateral side above the dome. And then you don't have good stable bone for fixation until you get to the contralateral zone 2. Well, the CurvaFix allows us to achieve that by bypassing the comminution, bypassing both parasymphyseal zones, and bypassing your symphysis. I could talk for hours on the trials of getting the fixation across the symphysis, the technique in doing so, but I think that the technique of doing that is a little beyond the scope of this practice or the scope of this talk. I mean, we're trying to just, deliver a message and show some solutions. But this implant, and this is the 180 millimeter length implant, that's as long as they go at this time, but that still allows you to start on the outer table on the side of injury, go above the dome, cross the ipsilateral anterior fixation pathway, cross the symphysis, and anchor your fixation in the stable bone of the contralateral zone 2. So again, you're going from these two stable areas, bypassing all that fracture, bypassing the symphysis, and creating a stable environment. And with the stable fixation in the posterior pelvis, this patient's allowed the weight bearers tolerated right away. And we've done this a couple times now. Here's another example, going from the opposite side. You had a left-sided fracture through zone 1. There's comminution, poor bone. Bypass it, anchor that fixation in the contralateral zone 2. And here again, you can see we did the same thing. You're ending your fixation in that stable zone 2 of the contralateral hemipelvis. So the CurvaFix has really allowed us to expand how we treat pelvis fractures, especially in these fragility fractures of the pelvis, where that poor parasymphyseal bone is even more poor because they're osteopenic or osteoporotic. And a lot of these fractures are comminuted. So for the zone 1 and zone 2 fractures, this has really provided a way to bypass that parasymphyseal bone, provide good stable fixation, and allow these older patients to weight bear as tolerated right out the gate. So future progression of this. Currently, the implant, like I said, it only goes up to 180 millimeters at this time. There are 2 diameter options, 9.5 and 7.5. 7.5 is the one that I choose for the anterior fixation. But we could use, smaller diameter varieties would be beneficial. And then it would, we'll try to work on getting some biomechanical studies because, I've already had some feedback about where you're crossing a joint, the pubic symphysis, with an implant that hasn't been studied crossing that joint yet. But so far, initial results have been very promising. So I think there's a lot of opportunity for future study on transsymphyseal fixation with the CurvaFix implant. So, and